Welcome to the UK Medical Freedom Alliance. We are the most recognised and respected organisation campaigning for your right to informed consent, bodily autonomy and medical choice. We are the voice of ethical medicine.
Hello everybody, welcome back to the UK Medical Freedom Alliance. So this is another podcast in our series about assisted dying and the terminally ill bill that is now running in Parliament. It appears once more. We did think we might have seen the back end of it, but it appears that that's not so. So I'm very grateful today to be joined by not only Amanda Hunter, who's been really driving this series for us, and we've done already a couple of episodes, but I'm joined by Dr. Bob Gill, an NHS doctor, and Lord Reg Empey. So let me just tell you about Dr. Bob. Dr. Bob Gill is a family doctor and GP, trained and working in Kent since 2000. His activism in defence of the NHS started in 2012 after the downgrading of his local hospital, which was then followed by the threatened closure of the accident and emergency department at a neighbouring hospital. As part of the Save Lewisham Hospital campaign, he began to learn of the history of assault on the NHS and how health systems elsewhere compared to England's groundbreaking Beveridge model, rising from the ashes of World War II in 1948. So with the successful battle in Lewisham over, he continued to campaign to try and raise awareness across the country about the political goal to repurpose the NHS into an American-style private insurance-dominated model. And he's spoken across the country supporting local groups in their own defence of healthcare provision. Lord Reg Empey, born in Belfast, Northern Ireland, has had a distinguished career in politics and public service, which I think goes without saying. That kind of underplays it, I think, Lord Empey. He served as a Belfast City Councillor for many years and twice as a Lord Mayor of Belfast. He was a member of the Legislative Assembly for East Belfast from 1998 to 2011 and held several high-profile positions in the Northern Ireland Executive, including briefly serving as acting First Minister of Northern Ireland in 2001. And he was appointed as a life peer in the House of Lords in 2011. He's been an outspoken opponent of assisted dying legislation, and during the 2025 and 2026 parliamentary debates on the terminally ill adults end-of-life bill, sought to draw attention to the lack of detail in the bill. I think I'll end there because I'm pretty sure that we're going to cover a lot of that information as we go through this, I think, very informative chat. So Amanda, you're driving this, but do you want me to start with the video that you were hoping to play?
Yes, I think that kind of sets the scene about what we're talking about here.
We've got what looks to be a postcode lottery in provision. We also have the terminally ill adults end of life bill coming down the pipe, which has an auto commencement clause after 4 years, whatever the state of social care. As Health Secretary, do you think it's safe to pass legislation with auto commencement in it after 4 years against this backdrop?
That is a decision for Parliament.
As Health Secretary, do you think it's safe?
Government is neutral on the...
I appreciate that the government is neutral. I'm not asking you whether you think what you think we should do. Do you have safety concerns?
I would like to make sure that were Parliament minded to proceed with the bill and see it through to completion and onto the statute books, I would like to make sure that we have high quality palliative end of life care services so that there is a real choice and no one feels compelled to take up an assisted death through the absence of palliative and end of life care services. That is not where we are as a country at present.
Do you think auto commencement puts that at risk?
Yes, please, Permanent Secretary, save me from this line of questioning.
Reg, I was very interested in having your insights today because, of course, now that the bill we've been told it's coming back, and Lauren Edwards is going to introduce it via another private member's bill. When we know all the flaws and pitfalls of having a private member's bill for something so important, Would you like to comment on your views about this news and why you think it failed the first time? Of course, we're told by the other side that this was because of a number of lords seeking to block the bill, but we know that the fact is that the lords were presented with a bill that was so poorly scrutinised in the Commons, and that they had to then sort it out in the Lords and suggest, multiple amendments in order to fill the holes in the bill. Could you just comment on Lauren Edwards' decision and why you think it failed and why it shouldn't be coming back again?
Well, first of all, the bill being reintroduced is entirely a matter for the House of Commons and wouldn't be appropriate for me to speculate on what they may or may not do. That is their business. But when the bill came to us, there was an awful lot of misinformation. First of all, this is the largest private member's bill we can ever remember or record. It was 59 pages long and it had over 50 clauses. And normally a private member's bill might have 4 or 5 pages and have maybe no more than 10 clauses. So it was a huge bill. So the idea that this was only amended by a handful of people is also nonsense. There were literally hundreds of peers participated in the debate. And also the number of amendments, 1,200 was quoted, this seems enormous, but this is because of the size of the bill. And in our House, any amendment that you put down at least is on the paper, whereas in the House of Commons there are a limited number of amendments chosen by the Speaker. So we've different procedures, but we didn't even spend as long on the bill as the House of Commons did. And yet normally it takes 1.5 times or twice the length of time for us to scrutinise a bill as the House of Commons. So the idea that this was all sort of a filibuster is mistaken. The average speech was about 4.5 to 5 minutes. And that's not a filibuster. I know about a filibuster and how to do it, and that is not it. So, look, it was the proposers of the bill made 77 amendments to it. So, in fact, and also you've got to remember that you're not taking 1,200 amendments, starting at number 1 and ending at 1,200. They're grouped. Sometimes you could have 60, 70, 80 in a group. So, it's a myth that each of these is debated at great length. It's not. They're grouped. That's the way legislation is done in Parliament. So we came to the conclusion during the passage of the bill that it was fundamentally unsafe. And that is the biggest criticism I think there is of it. It is fundamentally unsafe. It's not thought through. I don't think a private member's bill is the right way to do it. If you're going to do it at all, I think it has to be a government bill with all the resources of the state becoming available, instead of it being done half-baked. And that's really why the legislation, when it was heavily scrutinised, it didn't cross well.
And could you just comment on, so for our viewers who may not understand, how this works. So when a private member's bill comes back, the bill that is presented has to be exactly the same bill, does it not?
Well, if you're using a thing called the Parliament Act, and we could get terribly technical here, it has to leave the House of Commons in the same form as it came to us initially. Now, the proponent of the bill has been ambivalent as to whether she was trying to use the Parliament Act or not. Because when people asked her, was she prepared to accept amendments, she didn't rule amendments out. So if she's prepared to accept amendments, that is a different bill. So it's not clear yet how that's going to play out, and we'll not know probably till September.
So if it's a different bill, does that mean it can then go back to the House of Lords?
Well, it'll come back to us whatever happens.
Oh, okay.
Because all bills have to pass both houses. So using the Parliament Act is a very complicated procedure. It's rarely used. Don't think there's ever been a case of it being used for a private member's bill. But that's not to say it couldn't happen. But you're into very, very uncharted territory here. Whatever happens, House of Lords will have the ability to put forward amendments, whichever way it works.
Mm-hmm. And of course, she has threatened, hasn't she, to use the Parliament Acts. And those who are supporting her, I saw an article today by one of the MPs who's supporting her, who also brought up the question of the Parliament Acts. And we hope it won't be necessary, but, so there is that danger. So going back to Wes Streeting, as we led into the discussion here, I mean, he really struggled to reply to that question honestly, and floundered. So he does not think, and this is the ex-Secretary of State of the House, he does not think that we are in the right place with palliative care and end-of-life care for this bill to be safe. He didn't say that, but that was the implication. Do you think anything has changed since he gave that evidence or his answers to the committee? And where do we go from here?
Well, things haven't changed insofar as palliative care is a postcode lottery. And I think it was Gordon Brown maybe made a statement at some point that, you would like to think, and the point Streeting was making, that people have a genuine choice. And it depends where you are. And the sponsor of the bill in the House of Lords the last time, when challenged by that, their answer to that was, well, it's up to the individual and it's their choice. And if their choice, if palliative care is not available, basically that was hard lines. So that was one of the objections that a lot of people had, that real choice was not actually available depending on where you lived. Some places it was available, in other places it wasn't. And we are talking about a national health service. And I have to say, I personally feel very uncomfortable about this process coming into the NHS at all, because fundamentally it changes the whole ethos of the health service.
Yeah, we will talk about that in a bit more detail, but I was thinking more, if we look at some of the fundamental questions, we'll come into you in a moment, Bob. If we look at some of the fundamental, because the bill was so skeletal, there's so little detail on it, that so much is left open to question, of course, also to delegated powers, which we will talk about a bit more later. But there's the unresolved question, of course, still, of whether this is going to be an NHS service, sit within it and be within it, or be separate from its core activities, or be under the private sector. Was there any indication of what direction the government was thinking it might be going in?
Well, the government hasn't. It remains neutral. And therefore, it wasn't responding to a lot of questions about these matters, because it said, this is a private member's bill, it's up to Parliament. We will deal with it if Parliament chooses to pass a bill.
Visit our website to get immediate access to our media and presentations, our campaigns, our podcast, our Substack, legal help with support, and our open letters. The address is ukmedfreedom.org. That's ukmedfreedom.org. You can sign up there to receive our newsletter, so you're notified then of our new campaigns, our open letters and calls to action, and any other important updates. Oh, by the way, you can donate there too.
So the government really wasn't coming forward with significant answers. It was more or less saying, we're neutral, nothing to do with us. Parliament passes it, then we'll address it. But the government itself has stood back. And this is the point I'm making to you. Trying to do such an extremely complicated and controversial bill on the basis of somebody's name being pulled out of a hat, because that is the process that this bill went through. I checked today, and the government confirmed that it is neutral. So it's adopting exactly the same position of neutrality as it did during the last process. So that's a difficulty insofar as it won't answer things to do with costs, where the money's coming from, how it's going to be done, how it's going to be ruled out. Then we've got the whole question of what happens cross-border, because the Scottish Parliament has rejected a similar bill, and the situation in Wales is also complicated. So there's a whole lot of issues in there. That's why, if it was being done at all, I think it needs to be a proper government bill. And even some of its supporters in the House of Lords will take that view, that it really needs to be done properly, because who's going to pull all these things together?
Exactly. You need the policy infrastructure, don't you, that goes...
Yeah.
So can we bring in you now, Bob? I mean, can you comment on the news that Lauren Edwards is going to bring back the bill back, and your view, considering your background and research into the NHS and the state it's in, whether it could be made safe?
Yes, I'm extremely disappointed that despite the efforts of people like yourself and many others, this bill has reappeared. I was hoping that it was dead and buried. I'm coming from a perspective of the front line and seeing what government's policy actually delivers to patients, and having studied the sort of legislative path, the series of legal changes that have really crippled the NHS. So we now have an NHS which is endemically dysfunctional. We only a week or so ago had a report from the Royal College of Emergency Medicine talking about the normalised corridor care that takes place, which is leading to tens of thousands of preventable deaths. And I have, in the last 3 months, witnessed what has happened to my patients, which is mounted to neglectful care, delivered by very overstretched A&E departments. One led to the discharge and death of a patient. One led to the early discharge of a patient totally unsuitable, who ended up almost immediately on return to hospital at my request in intensive care unit, and a 14-year-old girl with suspected abdominal problem discharged after having a blood sugar done, only then to go home and perforate her appendix. Somebody I had sent in. So my experience is the NHS is very unsafe, and what this bill is primarily going to start with is raising the issue of assisted suicide to the most vulnerable people in society, who may not have anybody to advocate for them. And as we've seen in Canada, this will be gradually expanded to include people who are depressed because they are in debt. And, the policy stream that consecutive governments have inflicted on the NHS is one of removing money from the delivery of care and creating as I said before, a dysfunctional, very bureaucratic, very administrative heavy source of funding to redirect away from delivery of care and to line the pockets of private providers, and a very bloated system which is costing a huge amount of money, estimates in excess of 20%, in terms of running this dysfunctional system, which, as you can imagine, is a huge opportunity cost, which could be very easily diverted to giving us world-class palliative care services across the country. So there is a huge mismatch between the rhetoric from people like Wes Streeting and the impact on my patients on a day-to-day basis.
Absolutely. And Bob, leading on from that, I mean, at FAME, Families Against Involuntary Medical Euthanasia, it's one of the things that we are deeply concerned about, is the context, because we always say the safeguards are only safe in the context in which they are implemented. And if you are introducing assisted suicide into a situation where the NHS is on its knees, social care likewise, there is no capacity. It's on the swinging door from home to hospital, back to or care home. unsafe discharges, all this. And then on top of that, we have what we call treatment ceilings, where people of a certain age, disability, are not being offered the care and treatment they should otherwise be offered. And that is kind of rationing. And we know that Wes Streeting, before he went out, was introduced the policy where GPs would have to reduce their referrals by 25%. I mean, where are those people going to go? I mean, it's just a disaster waiting to happen. So we feel this is extremely dangerous to introduce assisted suicide into this context. As a doctor, and I'll then turn to Reg again. As a doctor, how do you feel about the role of doctors in this? I mean, we're supposed to have 2 doctors, and this is supposed to be infallible. Do you think that is the case? How do you think it's going to impact the patient-doctor relationship and trust in the NHS and the profession more generally?
Yeah, so I think there has been a significant erosion of trust ever since COVID. The privatization that has taken place has in fact disempowered the profession. So we have a largely top-down organisation, and the way the NHS is now structured, your career progression, your incentive payments are all lined up for you to toe the line and do as you're told. So the scope for raising your concerns in a way that you won't be victimized or end up losing your career is very narrow. And the NHS is very good at making an example of whistleblowers. So, if you need to think of any scandal within the NHS, well, it's often revealed by a whistleblower. And if you follow the trajectory, the whistleblower is often hung out to dry, whereas the people who were actively covering up the scandal end up being promoted to some other position elsewhere in the NHS. So the NHS is not safe for medics to raise concern. People putting them forward for this job don't have a problem with euthanasia. So you have a self-selection bias. And, if you, not only do you have the people self-selecting who won't be neutral, but you will also have the diminishing input from the GP who knows the patient very well. And you will have patients and relatives who have been sort of pre-primed to expect this is now an acceptable way to go. So there is the sort of social acceptance, the normalization of this whole concept, which leaves people more vulnerable than they were before we were having these discussions publicly. And it's also notable certain celebrity advocates of euthanasia are themselves dodging the euthanasia question whilst promoting it to others. So you couldn't make this stuff up.
Exactly. Right. Reg, could you sort of comment, because I know that it's of great concern of yours, the impact this will have on the doctor-patient relationship. Can you add to what Bob has expressed?
I was an elected member for many years, and I know that one of the primary objectives of local doctors, particularly in a working class area, is to try and get people to come forward if they have symptoms, or indeed if they have tests or something, rather than leaving things to the last minute when their conditions have deteriorated. Translating all this down to the ground and not to North London, ideological orientated people. The local doctor, well, I'm not going to go near him. That's Dr. Death. He's going to sign me off. This is how a lot of people, particularly from an older generation, may perceive this. And the other thing you've got to understand, if you are the finance director of a hospital trust and you've got patient A who's got a series of very complicated problems, even though they might be treatable, that person may be costing the NHS over time quite a lot of money to treat. Whereas if that person could be persuaded or coerced into ending their own life, then they could say, well, look, we're going to save here. In fact, I see in Canada, they were even boasting about how much money they thought they were saving. So the coercion factor, and there is a sort of, and I tried to make this during the debates, a complete mismatch between what people think families are like and what they actually are like. Because families can be very loving environments where support is given, but they can also be very toxic environments. And when you have somebody who's maybe, and bearing in mind, before you even come into the area where people have language difficulties, cultural difficulties, how all of this is going to be translated to a patient through the system. In fact, under the proposals as they were, there didn't even have to be face-to-face intervention between the patient and the person who would be presiding over the process. So there's so many things that I feel haven't been thought out, and there's so much pressure points, so many pressure points could be applied. And you've got to remember in this country as well, we've a variety of cultures. And in some of those cultures, and it was drawn out by Baroness Nicholson during the debate, where some cultures, particularly women, don't realise they have their own rights. And that is sometimes, in some cultural circumstances, they more or less feel that they've got to do what they're told. And so many different things, so many different languages spoken. Now, with a patient who's seriously ill, translating all of that, getting that message across. And when it emerged that there didn't even have to be face-to-face contact, and that's important. I mean, I'm sure Dr. Gill, yes, of course you can deal with certain things on the phone, but sometimes you need to see a person face-to-face and judge what the medical and psychological condition of that patient is. These things are absent, which is why I say the whole thing is unsafe.
It's becoming so that the best way to stay in touch with the UK Medical Freedom Alliance is via our Substack, which you will find at substack.com/@UKMFA1. That's substack.com/@UKMFA1, where you'll find our articles and videos published. You can subscribe and be one of the first to get our very important content.
So, I want to bring you up on, not bring you up, I want to take us back to coercion, which you just brought up. So coercion, of course, comes in many guises, doesn't it? So it can be from an unscrupulous family member, it could be from a carer who is exhausted, not getting the support. It could be from, but it could also be from the medical profession. It could, there is ageism and discrimination, ableist discrimination within the NHS. This also feeds into your point about the finance director of the NHS and making decisions about who gets care, but on the balance of costs. So and it also speaks to the question about the face-to-face. So can I ask you, Bob, and then maybe Reg, you can comment. How do you feel as a doctor, as a general practitioner, that the doctors that will be making these decisions have the skills necessary to spot coercion, to identify coercion? I mean, there's also, domestic violence. There are so many issues here. So as a doctor who has probably seen many of these scenarios, how do you feel that a general doctor is able to make that kind of call on whether someone is being coerced or not?
Yeah, so I think it's very much harder to make that call in the NHS as it is today compared to 10 or even 20 years ago. What the NHS has sought to remove is continuity of care. And it's done that by various incentive programs and legislative changes that they've already made. So continuity of care has been devalued. And what we also see going along with that is the de-skilling agenda. So you are removing the doctor from the primary caregiver to the family, and you're substituting in pharmacists, physiotherapists, and physicians associates. So you have a double whammy, a lack of continuity and a substitution of doctors. On top of that, you have organizational pressure in terms of work, with more and more hospital activity being dumped on the general practitioner. So in order to survive, you're having to learn to take shortcuts. And when you're working under a time pressure, when you're not actively surveilling for potential problems and pitfalls, you're going to take the path of least resistance. And that would be to say, yes, well, I see the situation you're in and I support assisted dying or euthanasia. But, there is the subconscious changes that take place without doctors realizing. And I caught myself in this dilemma maybe a decade ago when top down there was our directive to reduce unscheduled care for the elderly. Right. Now, it sounds like a very honourable thing to try and remedy. There was an incentive payment on the back of that, and we were sort of forced to come to a CCG meeting to hear how great this idea was. The only problem I found was when I went to see elderly patients, in the back of my mind was, are you an unscheduled care that I could avoid sending to the hospital? And I had to check myself. I said, why is my medical judgment and decision-making now changing because of this top-down propaganda exercise and potentially an incentive payment? And I consciously said, I am not going down this road. So I have turned up successive incentive payments to maximize continuity of care in my practice, and I have not taken on downskilling roles within my practice. But I put it to you, I'm in a very small minority of people who have put the way I work and the way I run my surgery and the way I try and maximize continuity as a non-negotiable priority. But I think most of my colleagues are no longer in that situation. They've been ground down and they have been financially engineered to try and grab every incentive payment and, unwittingly maybe bury any of their medical ethics and previously held disquiet in terms of making certain decisions on behalf of our patients.
Mm-hmm. I'm also, you make the point about physician associates. Now, we know that they are not supposed to be making certain decisions, but we also know from job descriptions, if you look at some of these job descriptions, they will be empowered to make end-of-life decisions. That is incredibly dangerous. This is people without the medical expertise to make that kind of call. And I think it also speaks, and we talked about this in previous panels that we discussed this on, Bob, is the trend towards the protocolization of medicine. And so that you've got this, rather than the doctor being able to look at his individual patient and the age of the patient, how the patient presents, their family, their support, everything that is going to help that person, he or she is following a tick box. And that is very, very dangerous in the hands of people like physician assistants who have not had that kind of, the necessary medical training.
Absolutely. I'll make you aware of a current scheme we have in our area, which is to try and combat some of these headlines. And they want to now provide a bit of extra funding, not significant, to employ more doctors in under-doctored practices, i.e. practices that have significantly replaced doctors with non-doctors. Now, the figures were quite shocking. So I'm my whole time equivalent GP to patient ratio is 1 to 2,000. There are practices where there's 1 GP to 7,000 patients. Now, this GP cannot have significant continuity of care with any of them, I put it to you. So there are other people doing his work. The NHS is now so deformed from its original ideals and inception that you can be an entrepreneurial GP, earn in excess of £200,000 a year, and never see a patient yourself. You just employ these non-doctor substitutes on a level whereby your income now is totally clinically free, and you're just raking in the money. Now, this is a model that will be expanded in due course for the hedge funds and other interested parties to move in and totally take out the GP out of the equation. That is the direction of travel that policy is taking us.
Yeah, it's frightening, and I think that this really, really does speak to how this will fundamentally, in the context that we have, the assisted suicide legislation would fundamentally change the purpose and the culture and the ethos of the NHS. And I know that's something, Reg, that you're quite concerned about. Would you like to comment on that?
Well, it is. I'm concerned about changing the relationship between the patient and the doctor. I made that clear at the beginning.
Mm.
But one of the main motivations of somebody who's seriously ill, and I've seen a lot of it recent years, they don't want to be a burden on their family. And that is a pressure in and of itself. And it's part of the coercion. Now, it's almost a self-inflicted bit of coercion, but it is a natural reaction. And I wanted just to take up a bit of what Dr. Gill said about his experience. Look, in a hospital, particularly if it's an acute hospital, there is a process called the doctor does their rounds in the wards. And this process is they have a mobile table with the computer and a screen on it. That's usually either a registrar or an F2, a junior doctor would be in charge of that. The consultant goes round and visits patients. He doesn't visit every patient every day, but maybe is able to spend maximum on a good day 10 minutes with that patient. And if somebody then is off on holidays, there's a different registrar who actually has to implement the recommendations of the consultant. So this is a very automated process. And to try and get across and inject an entirely new process into an overstretched NHS, which assisted suicide would be, with all the checks and balances that would be needed. We haven't even talked about the substances or the poisons that would be required to deal with them. I mean, people go into hospital to get medications to help them, but this completely changes the whole scene. So the idea that there's going to be a sort of a serious conversation with a family, and the family could have different views, it's just not realistic. Getting time with a consultant. Where I come from, there are hundreds of thousands of people waiting, sometimes in excess of a year, to get near a consultant. And the idea that we should be adding to that pressure when we haven't got things settled, as Dr. Gill has already said, I mean, I just don't understand the logic of that. And I think that it's my worry is that it would be outsourced. And you know what that's going to mean.
Yes, absolutely. Quite frightening. So can I just come to you, Bob, briefly? And can you talk, and we've seen the dire situation that the NHS is in. Can you talk a little bit about the NHS, the legacy of COVID, and also the gospel and LCP scandals very, very briefly, because the NHS has some form, and I think it's very relevant to the questions we're talking about now. Just very briefly, if you would.
Yeah, so the legacies of COVID were, first and foremost, the abandonment of established public health protocols in terms of managing a pandemic. This was very top-down. It was more of a psychological operation than a medical emergency, it turns out. The people leading it were behavioral psychologists, most of them coming out of the Behavioral Insights Unit within Downing Street. And what we saw was, under the pretext of health, a creeping authoritarianism whereby, logic went out of the window. You were told to lock yourselves down, avoid getting any sunlight, and maybe boost your vitamin D. And to wear masks that did absolutely nothing in terms of stopping the spread of this airborne virus. We were told to keep our distance from other people. Naturally, this had a major impact on society, not only economic, the education of our children, the isolation of our elderly, the suspension of important but planned surgical procedures, turning a hospital into a no-go zone when people were seriously ill with non-COVID related diseases.
And also the waiting lists, the long waiting lists that that has created.
Yeah, the long waiting list, and then to top it off, the forced uptake of, through coercion, in terms of losing your job or not being able to travel, of an experimental gene therapy, which we are now hearing many years down the line had many health harms rather than benefits. And studies that were done which were sworn to secrecy for 70 years, which were only revealed due to court action in the United States. So this was a huge shock to the system, undermining public health, undermining trust. And unfortunately, the vast majority of the medical establishment and health employees just went along with it, because we have now been conditioned over years to understand that resistance is futile. Unless you're of a certain very determined personality trait, you go along to get along. So COVID was very, very bad for the reputation of the NHS in this country.
And I was thinking, though, also, if I might, because we're running out of time. So I was thinking more about the kind of impact on how the elderly and the vulnerable feel within the NHS. I mean, how they are treated, how they feel that they're being put back to the back of the queue, that they're not getting the access to the treatment care, and they're quite frightened. I mean, George Fielding, who's a disabled activist, has said that bringing back this bill will devalue the lives of the disabled, and I think it will not only devalue the lives of the disabled but also the elderly, who also already fear hospital because of what happened during COVID. Many of them locked up in care homes, not getting access to to hospital treatment. And everything being triaged and not actually seeing a physician. So that kind of legacy obviously impacts how the elderly and the vulnerable view the assisted suicide bill. And of course, we know that no disabled group supports this, and no advocacy group, for example, for people with Down syndrome or people with eating disorders or the mentally ill. None of those bodies support the bill. They find it, they deem it to be unsafe.
The UK Medical Freedom Alliance is very proud to have our content in various places, including Substack, Rumble, YouTube, Odyssey, and of course our audio channels at Apple and Spotify. If you prefer social media as well as Substack, you can find us on Telegram, Facebook, and of course, X.
Absolutely. And we saw during COVID the almost the re-emergence of the Liverpool Care Pathway. Liverpool Care Pathway was discredited in terms of blanket use of opiates and respiratory suppressants. They weren't they were speeding up death. They weren't just withdrawing treatment. And then we saw the blanket do not resuscitate orders that were issued for mental health institutions, people in the care of the local authorities and private nursing homes, and the separation from their families. So there seemed to be no checks and balances in terms of what our patients were subjected to in terms of interventions that were hastening their demise, nice protocols that have now been quietly withdrawn. So that was hugely damaging. And, any government reassurance on that background should really be falling on deaf ears, given our recent experience.
Absolutely. I mean, I know, as you know, Bob, my own family were victims of the protocols during COVID and since, I have to say. So yes, I think it's extremely, these contexts make this bill so unsafe to introduce. I'd just like Lord Empey, Reg, could you comment, because you had the privilege, very briefly, you had the privilege, of course, of working alongside Lord Stevens, the ex-chief of the NHS. Could you just summarise his fears about the bill?
Well, he believes that it would require a rewriting of the fundamental documentation on which the NHS is based on. And he made a number of interventions during the passage of the bill which were extremely effective. But again, it comes back to the point that it changes the nature of the National Health Service. And I think his contributions were great. There is one thing we haven't mentioned here, and that is hospices. And they are being put under enormous financial pressure at the present time. And I think that there's a difference of view within the hospice movement as to how they should react to all of this and how they should respond. So I know that we'd one case where overnight hospice care had been withdrawn in a particular area because the hospice nurses they ran out of money and the service had to be withdrawn. So if you're trying to have a level playing field in all of this, there's a whole range of issues that have to be dealt with. But I would say fundamentally, my fundamental message is, as things stand, this legislation is unsafe. It hasn't been thought through in terms of its impact on the NHS. The issues surrounding coercion have not been satisfactorily addressed. And then there was a whole question of whether there was judicial involvement, because that was in the bill for more than half the time it was in the Commons. Then at the last minute, it was taken out. And a lot of people were saying that because a judge would be involved in it, they had greater confidence. But then on the other side of the coin, looking at, say, the family courts and so on, where's the capacity coming from to deal with all of this when the courts are backed up with cases? So all of these things were being answered on the hoof as we went along through the passage of the bill. I don't care what your views may be on assisted dying or not, for it or against it. But the fact is that given the circumstances of our NHS as it stands in 2026, it would be, in my view, irresponsible to put another high-risk strategy into the mix at the present moment when we can't even deal with things as we stand. As Dr. Gill said, COVID has done enormous damage to this country, not only to the NHS. It's done enormous damage to our economy. It's done enormous damage to how people even feel they don't need to work anymore. They've been brought up in a different way. It's done a lot of damage to a lot of young kids whose education has been interrupted, and they've been isolated. Particularly older people have been isolated in their homes. You weren't allowed to go near them, waving at people through the window. The whole thing was a ghastly experience. So whatever we do, let's make sure it's done properly in a coordinated properly thought through manner, and not simply based on how, if somebody feels particularly passionately about it, and none of us know how we're going to end our days. I understand there's people have genuine cases and have seen terrible things, but I think we must avoid being influenced by media personalities and so on, because that's not the way you do these sort of things. There's a proper process where government and parliament need to be acting together and do the thing systematically and correctly and thoroughly. And none of those things apply to this legislation at the present time.
Thank you very much, Reg. Is there any last thing you'd like to say, Bob, before we sign off?
Yeah, just that, in 30 years of being a doctor, I've only ever had one patient-initiated discussion requesting help to die. And it was an uncomfortable discussion, but this is largely based on irrational fear that he had of being left languishing in pain. And when I explained to him, fortunately, at that time, we had very good palliative care teams, and how he could be looked after at home or within a hospice, and how none of my patients to date, either they or their relatives, had any bad experience of palliative care when they could access it. So this is a private member's bill, which I suspect has significant, although statedly neutral, government support, for which there is no grassroots mass calling. This is not something that's a priority for the public. The public want a safe NHS, adequately staffed with competent people, and a bed to use when they need it, and a social service system which has the capacity to deal with people. We don't have that, and we're addressing all the wrong problems. And I fear that the government is using a crisis of its own creation to push through something which has a very malign intent.
Absolutely. Thank you very much, Bob. And I'd second that. You know, the fallacy that the public wants this, the public does not want this. Poll after poll, and especially recently, has shown that this is a very low priority for the public. The public did not ask for this bill. It was not written in any manifesto. And the more the public hears about it and gets to know about the complexities, the flaws and lacunas in the bill, the more it rejects it. And I think we should all reject it. And thank you very much for joining us today. What do you think the public should do now, both of you, if I might ask, to help our politicians focus on what they should be doing and reject this bill? What should the public do?
I think they need to try and get the head around the issue, try and see through that the sort of plausible, very soft and comforting narrative that is accompanying something of very great risk. And wherever they can, share this awareness with friends and relatives, and join up platforms such as yourself, such as the Together movement and other organizations that are actively campaigning to try and raise awareness. And, let your local politicians and MPs be aware that you're totally against what's being done in their name.
Yeah. Anything you'd like to add to that, Reg?
I think Dr. Gill's correct. The best way to do it is to email or pop a note to your local MP, not in an aggressive way, but in a just factual way. And I think MPs do take those sort of things seriously and take them into account. And I think that is something that's well worth doing, or write a letter to the local paper or something like that. It's simple. It doesn't cause any distress to anybody, doesn't put any inappropriate behavior, pressure on a member of parliament. They're under enough pressure as it is, but they're always interested in hearing the views of their constituents. And that's a very simple way of getting a message across.
And I think also, in addition to writing to MPs, to actually go and visit your MP and talk to your MP about your concerns face to face. So thank you very much. We do have some links that will be added for people to send a template. We have some template letters that people can adapt and send to their MPs. And we also have we will have some links to your films on the NHS, your research and your films on the NHS, Bob, the great NHS heist, etc., for all the viewers to have a look at. So thank you very much, and thank you very much, Ian, for hosting us.
Well, it's not at all. It's very, very close to our hearts at the UK Medical Freedom Alliance, and we'll continue to campaign as things move forward. I think these individual stories that the public tell as well are very, very important, because I think, unfortunately, there's a great swathe of people that believe that terminally ill people should be able to just die because that they're getting rid of their pain and their anxieties and everything else, and that it's all very much like it is in Switzerland, where you can just go and pay some money and take a sweet drink and then go to sleep. And it obviously isn't that at all. It's very, very different what we're facing in the UK. It's very, very similar, I think, to what's going on in Canada. We've had some fantastic discussions with the Canadians on this. And where they are, I know that's where we're going to end up. It's just obvious.
Yeah.
So it's very important. And I've had three of my own stories. I'm not going to tell them now, but they're very, very close to my heart. Things that have happened in the NHS and the responses. I went to a funeral on Thursday for a 36-year-old guy who was sent home with antibiotics and then died on his neighbour's doorstep. Because he had chest pains and they just gave him antibiotics. And that is just a very small story that kind of just tells a much, much bigger story as to what's happening at the moment where people present. And so if they're presenting to A&E and getting that kind of response, then what on earth kind of response are they going to get when they're lying in bed in a hospital ward and someone's suggesting that they might be dead in 6 weeks or whatever, so they ought to go now? It's very frightening, very worrying. So thank you all very, very much for your contributions, and I'll let you know when it's published. And for now, just keep fighting, and look forward to maybe seeing you again. Thank you.
Thank you very much. Thanks, everyone. Thank you.
I think this is a great time to remind you that when you get to the end of the video, if you're watching it on YouTube, you will find 2 links to further videos, which I'm sure you will find fascinating. And it's also a great time to remind you to click follow and like and subscribe so you're alerted when our new videos are published.